Hello, a very good evening, good afternoon, and good morning to all of you. We have reached episode 22 of this initiative started by me and Professor Fobi, the virtual Bariatric University. And today we are back again with one of the most interesting procedure, one of the most talked about procedure, one of the most controversial procedure, one of the most commonly performed procedure, and also one of the most effective bariatric procedure. I'm talking about laparoscopic one anastomosis mini gastric bypass operation. At the outset, I would like to welcome Professor Wei Jei Lee from Taiwan. Dr. Wei Jei Lee is a genius. He's one of the most brilliant surgeons I have ever come across. He's a professor of surgery at the Minshang General Hospital and National Taiwan University. He is the president of Taiwan Society for Metabolic and Bariatric Surgery, the director of Asia Pacific Endoscopic Bariatric and Metabolic Surgery Center, the chairman of Asia Pacific Diabetes Surgery Group, and the past president of Taiwan Association of Endoscopic Surgery, Asia Pacific Metabolic and Bariatric Surgery Society, and also Taiwanese Society for Metabolic and Bariatric Surgery, the IFSO, Asia Pacific chapter. Professor Wei Jei Lee is, as I said, one of the most learned, brilliant surgeon, and he has that special knack of publishing on some of the most burning issues, some of the most contemporary issues in bariatric surgery, where we were unable to find answers or adequate solution to our problems. I welcome you, Professor Wei Jei Lee, to this meeting, and we have always learned a lot from your experience, from your data, from all the important thought process you developed about mini gastric bypass and around it. We have my own friend, a very close colleague, K.S. Kolar from India. Me and Kolar, we have a very long relationship. In fact, if Kolar would remember, myself and Kuldeepak were the first two surgeons to host Professor Rutledge and start mini gastric bypass in India, when I think no Indian surgeon was performing this surgery. And, we have been condemned across the board for most of our presentations way back in 2010 and 11 for this procedure, which has now become a household name. Professor Kolar is one of the finest human beings, and I'm proud to have him as my friend here on Virtual Bariatric University. Kolar heads the Kolar Hospital in Ludhiana. He is a founding director of the MGB OAGB club and the founding president of the same club. He's a joint secretary of OSCE, and he has been trained by Professor Rutledge. And that association between Kuldeepak and Professor Rutledge has helped not only me, but thousands and thousands of surgeons across the globe in mastering the art and understanding the concept of mini gastric bypass. Welcome, Professor Kolar. I have another great, I would say a stalwart in the field, Professor Jean-Marc Chevallier from France. Professor Chevallier is one of the most respected and senior surgeon in International Federation for Surgical Obesity Society. He is a professor of anatomy and surgery both at the University of Paris in France. He is the president-elect for the IFSO European chapter, the co-founder and the past president of SOFFCO, the French part of IFSO. Dr. Chevallier was the president of the 14th World Congress of Paris in 2009. This was one of the first meetings I attended. I would say international meeting I attended as a bariatric surgeon. He's a member of the editorial board of the SARD and obesity surgery both, and has authored more than 200 scientific papers, editorials, textbooks, and video productions. Professor Chevallier have been somebody who I would say really gave that recognition or got this recognition for the mini gastric bypass. The mini gastric bypass procedure, unfortunately, despite one of the most effective bariatric procedure, is marred by controversy. And I think I have no hesitation today to say that it was Professor Chevallier whose seminal work got mini gastric bypass the well-deserved name it should have got long before. Welcome, Professor Chevallier, and we have a long association, and I'm so happy that you accepted this invite from me and Professor Fobi, and you're here as one of the important contributors to this show. I have another friend, Professor Thomas Walsh from US. Professor Thomas is a bariatric and general surgeon and practice at Novant Health Bariatric Solution in North Carolina. He's the founding board member and executive medical director of Practice Directions, which is a management service organization. Also led to the creation and accreditation of comprehensive cancer program at High Point Regional Hospital in North Carolina. He has a very high volume bariatric surgery center, does around 500 bariatric procedures a year. And it's an honor to have you, Professor Walsh, here. And, we would be enlightened by your comments upon this procedure, which unfortunately is still not accredited by the American Society for Bariatric and Metabolic Surgery in United States of America. I have the honor of introducing another great friend, colleague, mentor, teacher, and a good human being, Nasser Sakran from Israel. Nasser is the director of Advanced Laparoscopic and Bariatric Surgery Unit at Emek Medical Center in Afula in Israel. He's the director of Bariatric Surgery Medical Center. He's a clinical assistant professor at Technion, the Israel Institute of Technology. He's the president of Israel Society for Bariatric and Metabolic Surgery, member of the executive board of Israel Surgical Association, member of the steering committee for Israel National Bariatric Surgery Registry. He's a member of IFSO EC Multinational Advisory and the member of the editorial board of Obesity Surgery and reviewer for SOD. Nasser has huge amount of experience in different type of bariatric procedures, including biliopancreatic diversion, mini gastric bypass, and RYGB. And these days, he is a big proponent of one anastomosis gastric bypass. Nasser, we have been together in many meetings, and I've always appreciated the way, you put your views very honestly and very scientifically without any prejudice. And that's what I appreciate about you. And that's always coming in the light of wisdom you develop because of thorough experience and knowledge you have. Welcome to this show. I hope we will learn from you today and look forward to interacting with you. We have Priscilia Antozzi from Argentina. She is a bariatric and metabolic surgeon at Centro de Espellis, Bahia Blanca in Argentina. She is the vice president of the Argentinian Society of Bariatric and Metabolic Surgery. Welcome, Priscilla. And you have been for the first time to this show. I hope to develop a long-term friendship and camaraderie so that together we can take this training and teaching and dissemination of bariatric surgery along, and I hope we'll have you in our next episodes as well. We have Professor Alexandr Neymark from Russia. Alexander is a great friend, and he is a great teacher to many young surgeons who are aspiring to foray into the field of bariatric and metabolic surgery. Alexander is the chief of scientific research laboratory surgery of metabolic disorders and chief of the surgical department of general and abdominal surgery at Malmazov. He is the president of Russian Society of Bariatric Surgeons and the past president of the Young IFSO. Alexander was somebody who actually established Young IFSO and took it to heights we see today. And now his legacy is being taken forward by several others. Alexander, it's an honor to have you here. And I was invited to one of your meetings where I should say here, on group that it was during the COVID times, but the way you conducted that meeting was tremendous. And I think that that was probably the first meeting which you organized during the COVID times in such a systematic way that it inspired many others to believe that even during the COVID era, the virtual meetings will still find its place. Congratulations, Alexander, and welcome to Virtual Bariatric University. It's again an honor, a pleasure, and I'm humbled to introduce my own brother, Dr. Mahak Bhandari, who was a fellow who trained under us and myself and Professor Fobi, and now is one of the chief consultants here at our bariatric program. He's a very young, dynamic, and technically very sound surgeon. He's a consultant at SAIMS Medical School and also at BHRC and Mohak Bariatric and Robotics. He is associate professor at Department of Surgery in SAIMS Medical School. He's also the secretary of the Trust Society, which owns this medical school where all of us work. He is a laparoscopic and bariatric surgeon at Mohak Hospital and is trained under Professor Fobi, and also is one of the managing trustees at the SAIMS Medical School. He's a combination of a very technically sound surgeon, a great clinician, and also a good administrator. We are so proud to have you on this program, and I hope that you interact more with the people around the world and learn more from them and demonstrate the kind of work we have done at this hospital since last 10 years now. Last but not the least, I host this show with my teacher, my mentor, my guru, more like a father, and somebody who made me what I am today, Professor Fobi. And that takes me to a position in this program where I should invite Nasser, Alexander, and Priscilla, and Mahak to moderate the first lecture session. Welcome all of you once again, and I look forward to a great interactive program.
So good evening, everyone. So now I would like to just get on with the show. So I would like to invite Dr. Wei Jei Lee, Professor Wei Jei Lee. He's from Taiwan. He's a professor of surgery at National Taiwan University and a past president of IFSO Asia Pacific chapter and a president of Taiwan Society of Metabolic and Bariatric Surgery. So, sir, we welcome you. Dr. Wei Jei Lee would be talking about the long-term weight loss outcome and resolution of metabolic comorbidities after OAGB. So please go ahead with the presentation, sir.
Hello, everyone. I'm Wei Jei Lee from Taiwan. First of all, I would like to thank Dr. Mohit and Professor Fobi for inviting me to join this 22 episode of VBU. I'm going to talk about long-term weight outcome and resolution of metabolic comorbidity after OAGB. This is my disclosure, and OAGB is now my leading procedure, consists about 40% of my procedure. Another 30% is sleeve gastrectomy. Another 30% consists of OAGB and revision. As you know, in the past 20 years, OAGB has strong evidence to show is non-inferior to OAGB in weight loss and resolution of comorbidities. Then about the long-term resolution of comorbidities, I will talk about according to my experience. And before this, I would like to explain the change of the technique in past 20 years. This is our recent online paper in Seoul. Explain the change of the technique. In the first 5 years, as you can see, we use the original literature technique. That is episode-2 anastomosis with a fixed 2-meter limb. Then in the next 5 years, we shift our technique. We use 36 French bougie to calibrate the gastric tube and tailor the BP limb according to BMI. So it varies from 1.5 meter to 3.5 meters. Then in the next 5 years, in 2011 to 2015, we changed our anastomosis to posterior wall and anchoring the efferent loop high. That's to make the foot strain go more smoothly into the efferent loop, and in order to avoid the possibility of bioreflux. Also, we fix the gastroenteral anastomosis back to entrance, so to avoid the torsion of the loop anastomosis. Then in the last 5 years, the major change is we counting the small bowel to make sure we had adequate common channel. This is to avoid the possibility of protein calorie deficiency when we extend the BP limb. Because we need to explain the technique, that is, the result is from this technique. So if you use different technique, the result may not be reproducible. So if you look at the upper GI series of this different technique, you can see at the original, it looks like a loop anastomosis. Then in the middle, it becomes to one limb going to efferent loop. Then in the last, we call it OAGB in situ. We fix the gastric tube and anastomosis back to entrance. So the gastric tube look like just sit in the original way in the lesser curvature side, and all the time going to the efferent loop. And it looks something like we are doing the study procedure. So this is the figure we are using now, OAGB in situ. And in our experience, this kind of fixation giving an even better quality of life after surgery and very good weight loss result. So then we are talking about the patient change in these 20 years. In these 20 years, although we perform about 500 cases in each 5 years period, but you can see there's significant change in the male percentage. They are increasing male patient and also increasing of the age. This is all due to increasing of the diabetes patient. Now this procedure is especially recommended for diabetic patient in our center. And now it's about 50% of our patient is diabetic. And in the peri-operative outcome, you can see the operation time actually is increased as the period going to now, but the patient still gain better recovery. So now the patient can be charged with a very short hospitalization. And when we extend our operation time to do more things to avoid the complication, so you can see the result, the major advantage in these 20 years is we decrease the major complication from 1 to 2% in the first 10 years to now is less than 0.5%. So we probably do 100 cases of OAGB a year, and we only see 2 major complications in past 5 years. So the procedure now is quite safe, and for even the patient is more diabetics with higher BMI. Then we'll talk about the resolution of comorbidity in the long term. And this data have been published in Surgical Endoscope 2018. It's a 15 years experience. As you can see, OAGB has a quite stable weight loss, up to 30% total weight loss in 15 years. This is a little better than sleeve gastrectomy and OAGB. Of course, there's some selection bias. So the character of patient groups is slightly different. In OAGB, they always tend to have a higher BMI compared to the sleeve group. Then we talked about the resolution of comorbidity. In this paper, we investigate 4 kinds of comorbidity. The first is hypertension. we can see OAGB can achieve about 50% of resolution of hypertension. This is comparable to the other two procedures. There's no difference between these three procedures. Then we will see the diabetes. OAGB can achieve around 80% of type 2 diabetes remission in the long term. And this is slightly better than OAGB. However, it looks slightly inferior to sleep. Sleep can achieve 100% in the long term. However, as we know, this selection bias, we will talk it later. Then we look at hyperuricemia. OAGB can achieve around 60% remission of hyperuricemia, which is compatible with the OAGB and the sleep, although slightly inferior. Then the last is dyslipidemia, and the only significant difference exists in OAGB with sleep. OAGB can achieve about 70% resolution of dyslipidemia. And on the contrary, sleep can achieve 30% around remission of dyslipidemia, which is significantly inferior to gastric bypass procedure. I think this is the most important difference we find between different procedures. Then we will look at more deeper into diabetes. In this paper, compare the sleep gastrectomy with gastric bypass, which of course include OAGB and OAGB. In the whole group, you can see the type 2 diabetes is similar between these two groups. The remission rate is all around 60%. However, if we stratify the ABCD score, we can see there's difference in every ABCD score. Gastric bypass universe had a better type 2 diabetes remission comparing to sleep if we compare the same group of patients. The AB score is scoring system for predicting type 2 diabetes. The higher the score, the higher the remission rate. The lower score means the less preserved our beta cell function in this group of patients. So we cannot compare orange with apple. We need to compare on the same basis of patient character. So if we want to compare the type 2 diabetes remission, we need to compare the same group of patients. So we can use the ABCD score as a stratified method to compare different procedure for its efficacy for type 2 diabetes remission. Then we see the difference between OAGB and OAGB. In this report, you can see OAGB had a better BMI reduction compared to OAGB. So this achieved a higher type 2 diabetes remission in OAGB than OAGB. However, we need to compare stratified group. So if we stratify the patient with BMI, we can see the only difference is in low BMI patient. In low BMI patient, OAGB had a higher diabetes remission than OAGB. And in high BMI patient, the difference is less significant. Then if we compare the ABCD score, again, there's no significant difference in high ABCD score, but we can see significant difference in lower ABCD score. So that means in low ABCD score, OAGB superior to OAGB in type 2 diabetes remission. This is a recent online paper in obesity surgery. It's coming from multi-institute of Asia, ADSS study. So we compare all the procedure using for type 2 diabetes treatment. And the OAGB achieves the highest remission rate in type 2 diabetes remission comparing to other procedure. However, if you look at the sleep gastrectomy, the remission rate in sleep is higher than other bypass procedure as well. But this is, of course, due to patient selection bias. So when we look at the procedure remission at different ABCD score. You can see the OAGB, that is the black column, is out superior to other procedure, especially in low ABCD score. And you can see sleeve gastrectomy represented by a deep blue bar as a really inferiorly type 2 diabetes remission comparing to OAGB and other bypass procedure. So again, OAGB is superior than other procedure in type 2 diabetes remission. The last comorbidity we want to discuss is NASH. So because there's a controversial in the liver function after OAGB, there's some report to report the transient elevate of liver enzyme after OAGB. So there's a concern about the liver damage after OAGB in the long term. So this study using a NASH score to evaluate the resolution of NASH before and after various bariatric procedure at the long term. So in this procedure, you can see before surgery, in each group, there's all about 40% of the patient had the NASH diagnosis by the NASH score. Then years after surgery, you can see the remission of NASH is very high. There's less than 1% of patients still have NASH 10 years after different procedure, except the adjustable gastric banding. That, of course, is due to inadequate weight loss in this procedure. For the other three procedures, they had a very similar high efficacy in remission of NASH as well. So OAGB is also a safe procedure for the NASH population. Ladies and gentlemen, so the conclusion of my talk today is OAGB is a durable procedure which results in suspended weight loss and high resolution of comorbidities. And OAGB has slightly better remission rate compared to sleeve and OAGB, especially in type 2 diabetes remission and the resolution of dyslipidemia. However, standard technique is essential to maintain a good weight loss and avoid complication. Thank you very much.
Mahak.
Yeah. So thank you, Professor Lee. So it was such a nice presentation that OAGB is such a good procedure in countering all the metabolic conditions, especially the diabetes. So I've got some questions for you that I saw your presentation in the BP limb. What is the recommended BP limb? Because I can see that you wrote that it should be, the common channel should be more than 400 centimeters. So sir, can I know that what is the BP, standard BP limb you are following at your study or at your institute?
I now follow about 30 to 40% of the whole bowel length. In diabetes, so we want to extend about 40%. In non-diabetes, we usually follow the 30% bypass limb. Yes.
Okay, sir. So you measure the total limb and then you like decide that it should be 30 or 40%, or according to the diabetes status only you decide that?
Yes, if diabetic patient, I will extend as long as I can, but I make sure I have 4 meters behind. Yes. Okay.
So because the reason was that in the past years, when we used to do an OAGB with a BP limb of more than 250, 300 centimeters at our institute at Mohak, so we were finding patients with protein energy malnutrition because the Indian diet is mostly vegetarian also. So we reduced the limb to 180 centimeters. Dr. Fobi must be like, he made a protocol to make the BP limb as 180 centimeters here. That's why I was asking this, sir.
Yes, for me, fix a limb is not a reasonable choice because the patient we face from BMI 27 to 70. How can we fix a limb? And also the small bowel length varies in individual. And nowadays, I think the treatment should be individualized for every patient. So it's a precision medicine. So we need to think about the state of the patient, then choose our bypass procedure. That sounds more reasonable for me. Yeah.
Okay, sir. And
So
so
you
what
do measure the lymph length, the total lymph length before you do surgery?
Sure, no, every routine, yes.
Thank you.
And sir, in the low BMI patients, do you have any criteria of what should be the glycosylated hemoglobin in which you will attempt an OAGB on this particular patient, and what will be the BP limb of that particular patient?
I think I use the same principle. As long as I can do, yes, because I think it's important for the remission rate. And I'm more willing to do low BMI in young patient because we had a young patient in Asia. I think it's very important because the younger you have diabetes, the higher possibility for you have an end complication, cause your life death, yes.
Okay, sir. And so what is your opinion about weight regain in OAGB after your study, like if doing a 30% bypass, BP limb bypass, and what is your incidence of weight regain?
Very low, yes. In the old time, I made more malnutrition because I didn't count the common whole channel. So I do have some patients have short bowel. There are small lengths of the small bowel. So after I changed the technique, now I very rare to see severe malnutrition and also not very few to have a weight regain or something, yes.
Okay, sir. And in the NASH patients, you attempt an OAGB. So I would just like to know that normally in a NASH patient, we primarily go for a sleeve, or after you do a staged procedure, like doing a sleeve first, and then after some time, if you can go for a bypass also. So in NASH patients, you attempt OAGBs without any risk or without any choice, or you go ahead and you think. What is your comment on doing an OAGB on NASH patient?
I'm also concerned about that. So that's why I do that study. You can see I follow patient 10 years more, and we can see most of the patients don't have a NASH even after OAGB. Yes, so I think you can quite sure to do OAGB in NASH patient, of course.
Okay. And
but
what
of
would
course,
be
I will avoid in patient with cirrhosis. If patient already have documented cirrhosis, albumin is less than 3.8 something, I will not do OAGB.
Okay, sir. And the same concept of BP limb would be same in NASH patients also?
Yes. Usually patients have severe NASH. They also have hyperlipidemia, diabetes. So we treat the disease, I think is more important. Yes.
Yes. Thank you so much, sir. Thank you.
You're welcome.
Professor Antozzi.
Well, thanks. Now we'd like to introduce Dr. Kolar. He's a director of the Kolar Hospital of Ludhiana, Punjab, India. He's a joint secretary of Obesity Surgery Surgeons Society of India. Dr. Kolar has been personally trained and mentored by the father of the mini gastric bypass, Professor Robert Rutledge, and he's going to talk today about surgical technique of and management of perioperative complications after OAGB MGB. So we are waiting to hear you, Dr. Kolar. Welcome.
Thank you, Priscilla. Thank you very much for this nice introduction. So now I'll be talking about the mini gastric bypass technique. Just a second. Good evening, everybody. Today we'll be discussing mini gastric bypass, the original Rutledge technique, started in 1997 by Professor Robert Rutledge in North Carolina as a modification of the old Billroth 2 procedure, making a long, narrow tube along the lesser curvature and hooking it to about 180 centimeters down the DJ flexure. We understand that the old loop gastric bypass started in 1967 was associated with a lot of bile flux and the same stigma been associated with mini gastric bypass from the last about more than 15 years. But in the last 5-7 years, we see a lot of evidence showing that the bile flux in mini gastric bypass is from 1 to 2%. From our knowledge of general surgery, we understand that if you are doing a total, near total gastrectomy, Roux-en-Y connection is favored. But if you have a big stomach in hand doing a distal 1/3 gastrectomy, then a B2 is possible. So mini gastric bypass is a simple general surgical operation. It is similar Colles gastroplasty tube, which is a non-obstructive restriction. And then we have hooked it to the jejunum in an anticolic fashion with the B2 kind of loop gastrojejunostomy connection. Looking at the position of the patient on the operation table, the head of the patient is almost at the level of the head of the assistant who is standing on the left side of the patient. So it's a reverse Trendelenburg position, which has been reversed to the maximum. And then patient is facing the surgeon who is standing on the right side of the patient. So the maximum left side up position of the patient and maximum reverse Trendelenburg. Ports, rhomboid pattern. First port, 2 to 3 fingers down the Xiphi sternum. Then one right subcostal, one left subcostal, and one umbilical port. All these ports are equidistant from each other, about a hand's breadth away from each other. Left subcostal port for the assistant is a small one, 5 mm, whereas others are 12 mm. Starting below the crow's foot, making a wide window, skeletonizing the lesser curvature as posterior as possible, firing the first shot coming from the epigastric port to keep the tube as long as possible and to avoid the bird beak deformity. It's a 45 mm blue shot in general, keeping a wide base of the gastric tube and then going from the right subcostal and then further from the umbilical port. We shift the ports for firing the shots. Eventually, the camera goes to the left subcostal port. Going vertically up about 1 centimeter away from the G junction, keeping a small cuff there. Posterior dissection is done under vision with ultraseason. White tip, gastrotomy anterior, midline, and tracheotomy anti-mesenteric border, just sufficient to accommodate the tip of the step organ. Gastrojejunostomy is fashioned with 45 mm blue cartridge generally, and the hole is closed with absorbable suture with hand. So to summarize, the pouch starts below the crow's foot, avoiding the peak deformity by firing the first shot from the epigastrium. The tip of the pouch is wide, pouch is loose, non-obstructive. We avoid the G junction knowingly. Twist of the pouch is avoided as far as possible, and we don't dissect the hiatus. We understand from a lot of evidence which is in hand now that MGB has got a stronger BP limb because all of the bypass in MGB is nothing but the BP limb. So simple, elegant, effective, powerful, it can be tailored. You can make gastrojejunostomy here, or you can do it further down or proximal. You can even revise it or reverse it by undoing the gastrogenostomy and putting the stomach back to the stomach. Now, what can go wrong? The complications which can happen on the table while designing this mini gastric bypass: T-junction, the loop junction. So first of all, we need to understand that making the gastrotomy anterior, but firing the shot through the posterior surface of the gastric tube, and the staple line should be in the midline, vertically up, aligned with the gastric tube, away from the left neo greater curvature. Looking at this design, this blue line shows the posterior gastrogenostomy staple line, which is away from the left staple line on the gastric tube. And this red line shows a wrong way to fire the posterior staple line, going close to the left staple line and leaving a small ischemic island here. Then, to avoid the twist. So, what can we do to avoid the twist? See, after completion of the gastric tube, the pouch should be lying without tension like this, in a normal anatomical position. But sometimes you'll see this tip rotated where the left side has rotated towards the right side. The anterior has gone posterior. This is because of the wrong usage of the pores, the wrong firing of the initial 2 to 3 cartridges. And then we tend to make the gastrogenostomy on the anterior tip, on the anterior surface. But eventually when you take out your stepper, see here the stepper is being fired on the anterior surface during the gastrogenostomy. But when you take it out, finally at the end you'll see the loop is rotated because the stomach straightens itself eventually, and what rotates is the loop, and that is what causes the obstruction at the outlet. And this is some invisible illness. Patient is not feeling good, having retching, vomiting feeling all the times, reflux, endoscopy is showing nothing, CT scan is showing normal anatomy. But when you do a diagnostic laparoscopy, you find this rotated loop. Using the correct position of the ports, many a times we are tempted to use the sleeve ports because many of our new friends are coming to the MGB arena from a sleeve background, and we are already used to those ports. But we must remember that the first shot has to come from the epigastric port, keep the tube as long as possible, avoid the beak deformity. Look here, the right subcostal port is being used to fire the second shot, but the shot is going towards the spleen. Towards the spleen, we want to keep it horizontal. We want to make a wide base of the gastric tube. This red line showing the staple line. We don't want this angle because it's making a tight tube, rotating the tip of the tube. We want this horizontal line. This fire should have been horizontally towards the greater curvature. See, the tip has already started rotating. And when you go up near the angle of his, again, when you are using less number of ports or using the sleeve ports, there is an intention to use this rotating gun, but eventually you will find the final shot is not looking not that good. So it's better to use the left subcostal for the final shot and just keep 1 centimeter away from the G junction. And about dissecting the posterior window, it has to be done under vision with ultraseason. No blunt dissection to avoid injury to the short gastrics. At the time of gastrogenostomy, again, to emphasize, we have to go vertically up towards the head of the patient. So for gastrogenostomy, we use the umbilical port for entering the gun, not the right subcostal port, because then this posterior line will go close to the left greater curvature. So two stapler lines coming close, making ischemic area there, causing stricture, causing early ulcers. Again, using the stapler, the needle holder coming from the, here you see it's coming from the left subcostal port. It's better to switch the camera towards the right of the patient and use the right umbilical port for the right hand for the needle holder, so as to suture this gastrogenostomy nicely, keeping correct triangulation and not making a compromised kind of anastomosis. About the leaks, it's a very clear concept. Fresh leaks and late leaks. Fresh leaks are defined as 24 to 48 hours leaks, which are diagnosed early. And to diagnose the leak in mini gastric bypass, because of the bile coming out from the leak, even if it's a very small leak, bile, we understand it's quite irritating. Patient has intense pain, which is not relieved with general painkillers, the commonly used painkillers. Patient is not looking good, tachycardia. Guarding in most of the cases is not there initially. So pain when taking 2 sips of water, cruciating pain, not relieved with commonly used medications. Tachycardia is nothing but a leak unless proved otherwise. So we don't waste time doing a CAT scan and documenting the leak, because many a times the leak is very small and it's not picked up in the CAT scan, and we end up wasting more time. Just do a diagnostic laparoscopy, go in, and if you find the blue dye coming off from a spot, just fix it right away. It's a low pressure system. Now we know that mini gastric bypass is a low pressure system. If closed at right time, the leaks will close very fast. For the late diagnosed leaks, which are diagnosed later than 72 hours, just take down the gastrogenostomy and put the stomach back to the stomach. There's a consensus about this coming from the mini gastric bypass, MGB, OAGB Surgeons Club. It's not advisable to waste a lot of time on these sick patients, converting this into Roux-en-Y or doing some other procedure. We just need to unhook the gastrogenostomy, take it down so that the bile is down, and put the stomach back to the stomach, because it's a life and death situation. With this, I will finish my talk. Thank you very much for your patient listening. If you have any questions, you are more than welcome.
Antozzi.
Okay, so thanks, Dr. Kolar, for your presentation. I have a question for you. First, something to say that probably you said at the beginning that the MGB, OAGB technique, it's a safe and an easy technique, and easier than a Roux-en-Y technique. But as you show, there are many tips that you have to be aware of when you are performing the surgery, because one of the things that I first asked when I saw Dr. Walsh's technique was the twisting problem with the pouch. And probably one of the most important things that you said is the way that you perform the anastomosis. I have a question of that. You perform your anastomosis on the posterior wall with a 60 millimeters stapler line. Is that correct?
No, commonly we are using a 45 millimeter
Correct.
cartridge, and of course, yeah, in majority of the cases we are doing posterior, yeah.
And do you think that the dissection section of the lesser curvature is one of the important things to be aware of when you are performing your pouch to avoid twisting?
Yeah, so far as twisting is concerned, we need to understand that there are two surfaces of that narrow gastric tube, the anterior surface and the posterior surface. If you have fired your shots in such a way that anterior and the posterior surfaces are equal, then finally the tube will not rotate. So this comes gradually, over a period of time when you do it and see how it rotates. Once you take out the bougie at the end, you will see that the tube is lying in natural position without rotation.
Great. Do you have any length to be aware of the tube to perform it?
We see that the stomach volume varies according to the patient. In big volume eaters, we got bigger stomachs. So I think measuring the length of the gastric tube, our thumb rule is that start below the crow's foot. Do not go too much down into the pylorus because that is very thick area, and best is between about 4 centimeters away from the pylorus. So that is the thumb rule. Yeah, we need to get as much length as possible. Yeah.
And one last question for you. Do you measure the total length of the small bowel? Because as I know, Dr. Rales usually don't do it. I don't know if you changed related to malnutrition or deficiencies in the last time, or you keep doing a standardized length of the BPD and the common channel.
Initially when I started my practice, when I looked at Dr. Rutley's patients, his practice, I started following that right away on my Indian patients. But what we found was that Indian patients have more weight loss with the same length as compared to the American patients. So now we are a bit conservative. And in case if I have to go beyond 300 centimeters, then I would definitely run whole of the intestine. Maybe if not whole, because in about 1,000 patients, I have tried running whole of the intestine and tried to understand the permutation combination of the percentage kind of thing. But now I understand that whole of the intestine cannot be counted as one long tube. The proximal part, the jejunum, has the maximum absorption capacity. So if you are bypassing whole of the jejunum, then definitely your patient can have some high incidence of malnutrition. But in cases where you need, high weight loss, patient is having super obese kind of structure. So in that case, I'll definitely run whole of the intestine. Otherwise, if I am below 250, then because the minimum length which I could come across was 400. So yeah.
Okay, thank you very much.
You're welcome, Priscilla. Nice.
Okay. We're going on to our next.
Yeah. Dr. Kolar, you hear me?
Yes, sir.
Go ahead.
Okay. Thank you for the presentation and thank you for the topic. But my comment is that we are now in 2021, not in 1097. Because the technique what you have now, this is the same technique that we had before more than 20 years.
Yeah.
I am certain that I don't like when somebody said to me never, because I said all the time never say never.
Yes.
Okay, because you said that never dissected the hiatus. I am the surgeon that all the time I check the hiatus. I am approach for that when I check the hiatus, I can find, and I find all the time, but I think in 20 to 30% hiatus hernia. And I think when we find hiatus hernia, we must prepare this and we must fix the problem, okay? Not leave the problem. When you said never dissect this area, you leave sometimes big, sometimes mid hiatal hernia, and this I can't agree with you with this technique. What you said again, that you perform the anastomosis vertically. Okay, that means that you can have shorter pouch. We know that the pouch must be the longest what we can have, because we don't have, if we have very long pouch, you can have less bile reflux. And I perform horizontally the anastomosis end to side, not vertically. And that's mean, I think in 2021 we need to modify the technique, not all the time be fixed the same and I am the best and never all the time. I think we need to talk surgeon face to face, not say to me this is wrong, this is never do that. What do you think?
Okay, sure. Just 1 minute. First of all, I agree with you. There is no word like never in medicine. But, you know, my meaning of saying never dissect the hiatus, what I meant to say is, and we have this consensus, so you are also a part of the consensus there in the mini gastric bypass surgeons group, that basically, sorry, I would say mini gastric and OAGB, MGB OAGB surgeons group. So basically, we are of the opinion that if the hernia is asymptomatic, we don't fix it. We believe that the loop is pulling the gastric tube and the GE junction down, and it keeps the GE junction in the abdomen. And if at all, patient has uncontrolled reflux, which is not getting settled with time, we'll give it some time, let the patient lose some weight and come back after 6 months, 8 months, and then fix the hiatus hernia, because I primarily believe that mini gastric bypass is a very simple operation, and we try to keep it simple. And so long as the concept of changing the things over a period of time in the last 21 years is concerned, believe me, I have tried different permutations, combinations. I have tried making a tight outlet, making a very tight gastric tube over a 27, 24 French bougie also. But what I understand now is that if you make a very tight tube, patient cannot eat. I mean, the very principle of the mini gastric bypass, as explained by Rutledge and as understood by me over these 15, 16 years, the non-obstructive restriction, which is primarily coming from other things. So we don't believe in obstructing. So there are many such things, like I ran whole of the intestine and try to measure the percentage, but you know, eventually we come back to the square one. So that is the problem. Anyways, thank you very much for your comments. Thank you very much, Priscilla. Nice.
Move on to Dr. Neymark.
Hello, my friend.
Go ahead.
And colleagues. Thank you for invitation, Dr. Fobi and Mahak Bhandari. It's very nice to be here. And let me introduce my friend, Professor Jean-Marc Chevallier. He's a professor of anatomy and surgery at Université de Paris, France. He is the president-elect IFSO European chapter and co-founder and past president of the SOFCO French part of IFSO. Dr. Chevallier, please.
Dear colleagues, dear friends, it's a pleasure to be able to share with you such a webinar in this difficult period. Let me first thank Mal and Mohit for having made it possible. I used to operate in an academic center in Paris and have been doing bariatric surgery for more than 25 years. I began studying the OAGB 15 years ago in 2006. I tried to give data as academically as possible, publishing our long-term series in SWORD and all complications out of the first 1,000 in obesity surgery in 2014 and 2015. In long-term series, the rate of late reoperations after OAGB is between 2 and 10%. Main concerns are reflux, malnutrition, marginal ulcers. Internal hernia and insufficient weight loss are actually very rare. Out of 1,630 cases, for example, we had to reoperate 59 patients, 4 for marginal ulcer perforations, 1 for internal hernia through the Peterson space, 23 for intractable bile reflux, 16 for weight regain, and 3 for malnutrition. If a patient suffers from reflux after OAGB, the first thing to do is to give him PPI treatment. Most of the time, it will be efficient, showing that this is acid reflux. We have performed pH metry and will shortly publish that most reflux after OAGB are acid reflux. The rate of intractable bile reflux requiring surgery was 1.4%. It occurred 2 years after OAGB in patients who had lost all excess weight. Mean BMI was 25.7. In case of bile reflux after OAGB, it's mandatory to perform a second anastomosis. The easiest is to do the enteroenterostomy 70 centimeters down from the gastrojejunal anastomosis. But this could be dangerous. If the bypass was a regular 2-meter long bypass, the second operation will lead to a bypass of 2.70 meters, which could be too much if the total limb length is short. That is why it is mandatory to measure the common limb downwards and check that it is longer than 3 meters. If not, it is more advisable to resect the anastomosis and do a regular Roux-en-Y gastric bypass. The OAGB has been considered as having a risk of cancer because of the afferent flow of bile. The Japanese trial in rats, which is often reported, studied actually a total gastrectomy comparing esophageal anastomosis to Roux-en-Y. A recent hepatobiliary scintigraphy on 9 patients showed in 5 of them transient bile reflux into the gastric tube, but bile tracer was not found in the esophagus of any of the patients. The OAGB has nothing to do with a Mason procedure, actually. There must be a long and narrow gastric tube in between. And Ireland, from the team of de Mester, wrote already in 1996 that gastric content may protect from development of esophageal adenocarcinoma. According to this potential carcinogenic risk of the bile reflux, we performed experimental studies in obese rats, followed 16 weeks, which is equivalent to 16 years in human. We did histological and molecular analysis of the PCR of the genes of interest. We did not find any dysplasia nor metaplasia in the esophagus. The Bright ulcers markers and esogastric carcinogenic markers were not significantly different than sham rats after 16 weeks. The second potential long-term complications after OAGB is malnutrition. It seems limited in most long-term series, 0.2 to 1.3%. We had actually 3 cases with excess BMI loss between 119 and 124%. They required reversal to normal anatomy after parenteral nutrition. This reversal was an easy procedure: resection of the gastrojejunal anastomosis, gastrogastric linear stapling, and jejunal linear stapling. In the recent E-omega trial, 127 Roux-en-Y have been compared to 128 OAGB, which were 2 meters long OAGB. After 2 years, there were 9 nutritional complications in the OAGB group, known among the Roux-en-Y. Our study in rats confirmed actually that fecal protein loss is significantly higher after OAGB than after Roux-en-Y. It is important to remember that even if total limb length is supposed to be around 6 or 7 meters, extremes are very different between 3 and 12 meters. A 2-meter jejunal exclusion, if total bowel length is 5 meters, has different effects than if total bowel length is 10 meters. This recent study compared 3 OAGB according to BP limb length, 150 in blue, 180 in orange, and 250 in gray. Protein deficiency are much more frequent if the BP limb was 250 and above. To avoid malnutrition, we compared 2 meters and 1 meter 50 long BP limb. The decrease in BMI is very similar if the BP limb is only 1 meter 50 for patients with a preoperative BMI under 50. It is not necessary to bypass more. This has been recently confirmed by this study. A BP limb above 1 meter 50 could be associated with serious malnutrition rate. And this is what occurred in the E-omega trial. Marginal ulcers can occur from 0.5 to 8%. We had a rate of 2.7%, 44 cases out of 1,630. 4 of them required emergency surgery for perforation. All were heavy smokers. The rate of internal hernia is very rare, 1 out of 1,630 cases in our experience, because in the OAGB there is only 1 anastomosis and no mesenteric defect. We published recently 16 patients who had weight regain. As seen in this upper GI series, the gastric pouch was dilated and we could perform a pouch resizing with good further weight loss. Overall late complication rate after OAGB is in conclusion quite small. Estimated revision rate is at 12 years was around 3%. Most common cause was reflux, but most frequently reflux is acid reflux and PPI treatment will work. Intractable reflux rate was 1.5%. It requires conversion into Roux-en-Y, taking care of the total bowel length. The common limb downwards must be more than 3 meters long. Weight regain can lead to sleeve resection if the pouch is dilated. Malnutrition is rare if the BP limb is less than 1 meter 50 long. And this is the important take-home message. Of course, we need further results, 10 years results, studies, and endoscopy. I thank you for your attention and hope to see you safely again.
Thank you. Okay. Neymark?
Okay.
Thank you. Thank you, Jean-Marc.
Thank you very much for your nice introduction. And well, I will be happy to answer questions, if any.
Yes, I have a few questions for you. In a case, if you had a small bowel only 3 or 3.5 meters, what you will do? For example, because first step is creating of pouch, you create a pouch and then you start to count small bowel. What you will do?
It's a good question. We didn't advise to measure the total limb length in any case because we found that, well, short bowel is quite rare, but it's true then, well, you will not see that because you will not count the bowel and you will see it afterwards. But that's I think the most important reasons why we decided to change from 2 meters to 1.50 meters. It's because it's less dangerous and it's as efficient than 2 meters.
Okay, thank you. Because I had a situation for redo when there was only 1.50 meters, and it was a problem to what to do. It was a big malnutrition. At all small bowel was only 3 meters, and sure we restore the anatomy and stop and for next steps. Okay, the next question, it's about ulcers of anastomosis, because I hear many different opinions, and sometimes the data, it's about 15% for these ulcers. And what do you think the real numbers, and what the prophylaxis of this complications can be?
Well, in the overall studies, the rate of marginal ulcers is between 2 and 8%. In our experience, it was 2.5%. Well, I think most of the time, when there is a marginal ulcer, first of all, it's a smoker. So I think it's very important to either convince the patient to stop smoking, or if not, to give him PPI treatment. But most of the time, the medical treatment will work. You see in the slide, I've shown a huge necrotic ulcer. This study is very interesting because it was a woman who suddenly could no longer eat after, well, 1 year after an MGB. And she had such a necrotic ulcer. She was a heavy smoker, but we gave her PPI treatment, and then everything went okay. The most severe in our experience were the perforations, because we had 4 perforations which occurred 2 or 3 years after the MGB in patients working but still smoking, and they suddenly perforated. So it's really a big concern. It's rare, but I think the patients must be convinced to stop smoking. That's the only thing that we can do, and give them PPI treatment, or do not allow them to have a bypass if they are still smoking.
Okay, thank you. The little comment about it. I think because many patients, we do the upper GI endoscopy routinely for these patients, and many patients have the ulcers without symptoms. And sometimes you see very big ulcers and no symptoms. And maybe the reason why the person not so high, it's very interesting to know, because I speak with different colleagues in any regions, and it's very different numbers. Okay, and one of the little questions, what you think about hand-tuned anastomosis for the OAGB?
About what?
Hand-tuned anastomosis.
Hand-sewed anastomosis. Sewing by hand without staples.
Without staplers. The anastomosis without staplers.
Hand-sewn.
Yes, hand-sewn anastomosis.
But I do the anastomosis hand-sewn. I do a vertical stapling like Kolar on the posterior surface, and then I suture it hand-sewn.
Okay, no, I asked about totally hand-tuned anastomosis because maybe it's less of the ischemia of the pouch, and it's maybe.
I'm not sure ischemia is often the reason of the marginal ulcers, because in our experience, it occurs very late, 2 or 3 years after the anastomosis. So it's very different from marginal ulcers that can occur very early, and then there could be ischemia, but it's very rare. It's mostly late marginal ulcers.
Thank you. I think we're a little bit out of time, so many questions, and maybe somebody from the panel want to ask the questions for you.
Mm-hmm.
No, thank you.
Okay, we'll move on to the next. Yeah. Unmute yourself.
I don't hear anything.
Yeah, it's coming. Dr. Sakran? Nasser?
It's from the United States, Dr. Thomas Walsh, and he practices in.
Your audio is very low.
Go ahead.
He's from North Carolina. He's also one of the bariatric surgeons that we have today, and I am happy to that the topic that he have about the gold standard. Okay, maybe we'll discuss after that what's mean gold standards procedure of bariatric surgery. We can discuss after that, and again thank you, and you can have your topic.
Dr. Walsh, presentation.
Well, good afternoon, good morning, wherever you may be. I'm Tom Walsh for Novant Health Bariatric Solutions, located in the Triad of North Carolina. I really appreciate the opportunity to share our experience and our strong feelings, if not biases, about the OAGB. Just a quick word, can't stand the name one anastomosis gastric bypass. There isn't a patient I've met yet that can say that name. We call it a sleeve gastric bypass. When Bob Rutledge taught us how to do this years ago, it was a mini gastric bypass, and that name evolved for obvious reasons. No conflicts of interest, certainly none overtly that I recognize, happy to say. And so, as I mentioned, we are a program called Novant Health Bariatric Solutions. It includes surgical bariatricians, medical bariatricians, nutrition psychologists, exercise, and now a partnership with a organization called Core Life that helps us expand our footprint across the entire central portion of North Carolina. I'm Tom Walsh. My partner is Jim Dasher. You can see here what we do, where we came from. Suffice it to say that we've been doing bariatric surgery exclusively for the last about 7 years. Did a mixture of bariatrics and general surgery probably for about 10 years prior to that. So a fairly extensive experience. And our earliest experience was under direct tutelage from Bob Rutledge with the sleeve gastric bypass. We evolved that to a new, what we think is improved version of the Roux-en-Y gastric bypass, and then on to sleeve gastrectomy. Here's our case mix disclosure, and you can see mostly it's over the last 6-7 years has been sleeve gastrectomy with a mixture of Roux-en-Y and OAGB. To put it in maybe a little simpler graphic form, this is our surgical volume by procedure as of 3/10/2021. What's interesting, though, is based on the data I'm going to present today, we've evolved quite a bit what we advise patients to do. The patient always gets to choose what operation they have done, but at the end of the day, we are supposed to be giving them advice. And so as we've learned about the significantly improved safety and efficacy of gastric bypass, especially OAGB over sleeve gastrectomy, our numbers have shifted a little bit. And if you look just at the last 12 months, and the previous 12 months was the same story, I just had our database manager pull up the most recent data, you can see that more gastric bypasses are being done and fewer sleeve gastrectomies. And when you combine them together, this is essentially what our practice looks like now. So here is the sleeve or mini gastric bypass, the OAGB. And this slide is a little misleading. There's the obvious, sleeve-shaped stomach hooked up to a loop of small bowel coming up. About 1/4 of the small bowel is in the biliopancreatic limb. About 3/4 of the small bowel is distally in the intral limb. Do we measure out the entire small bowel down to the terminal ileum? No, we don't. Have we overdone it on some people? 4 so far, where we've been a little off in our estimation of 1/4, 3/4, and a couple of ladies had more like 50-50, and that was a little strong for them as far as the amount of weight loss, some diarrhea issues, which we never see. I think most of our patients are constipated postoperatively due to their improved diet. This slide's a little misleading, and I want to talk about that for a moment and do my drawing here of the surgical technique that is actually essential in the success of these patients and the safety of the operation. So esophagus going down through the hole in the diaphragm, stomach. It is very important to mention, and I've seen quite a bit of variability in the technique that is used in many papers as reported. Ours has evolved a little bit from what Bob Rutledge taught us, and for very good reasons, the main run of which is to virtually eliminate the bowel reflux issue, but certainly make it a very, very minimal concern. And that is that if we look for the crow's foot coming down and the incisura, which is usually a little more obvious than in this drawing, we make sure that we get down past the crow's foot, a couple of centimeters past where the lesser curve is going down. It starts to go towards the patient's right. So we're making our first, slice there, our first notch with the GIA stapler, usually a green load on the Ethicon endo-GIA stapler, before we're marching on up this way. So again, what we've created is the esophagus going down through the hole in the diaphragm, our tubular or sleeve-shaped stomach, ergo the name sleeve gastric bypass, with the staple line here and here, 3 staple lines here and here, and of course the rest of the stomach bypassed over to the side. Make a big deal in our presentations to the patients of emphasizing, that's your new stomach. Is that a little bit of an exaggeration? Yeah, it's a little bigger in caliber, a little and 2 or 3 centimeters longer, but they get the point is that it's a dramatic, reduction in the volume of the stomach. We do it over a tummy vac tube, and we kind of sneak up against it and then back off a little bit is the best way to describe how big we make the caliber of our stomach. Dr. Rutledge taught us years ago, and we really agree that the smaller the caliber of the stomach, not in length, but in circumference, the smaller the better. Unlike sleeve gastrectomy, where smaller can lead to more leaks and strictures at the incisura, we don't see that being an issue in sleeve gastric bypass. So then we're going to head on downstream, calculate about 1/4 of the small bowel, and bring it up and do an end-to-side anastomosis with the linear staplers, endo-GIAs, and oversewing with a vicryl endostitch. So that's the operation. The key technique point is getting significantly, noticeably past the crow's foot into a little bit of a bare area here before the other vessels start kicking in, and definitely past the incisura. We've read quite a few papers where the stomach tube was divided up here. That's, in our humble opinion, not the right way to do it, and probably leads to a lot of the reflux issues. We scoped a lot of people routinely for early years in our program, and occasionally saw bile in the stomach. Quite honestly, never saw bile in the esophagus. Our GI doctors help us with that now. So here's our version of the Roux-en-Y gastric bypass. What is this? If you look at it, it's an SGB, where we just simply come around the biliopancreatic limb, divide right there, swing this around, and reattach it further downstream. That's all this is. So we maintain this very healthy sleeve-shaped stomach. Big advantages for the patients in this. One, we never see a B12 deficiency, ever. I think it's more common for us to see B12 excess because so many people take those very expensive bariatric vitamins, which our patients don't need, and or are told take extra B12, et cetera, for energy, which never works out. So we often end up decreasing their B12 consumption post-operatively. Also, the gastrojejunectomy is way more accessible. Should we develop a leak, which most likely would be there, right? Much easier to fix than a gastrojejunectomy that's up here, up against the diaphragm, underneath the left lobe of the liver, between the spleen. You get the point. Down here also, if we do develop an anastomotic ulcer that is not responsive to medical therapy, revising that gastrojejunectomy is certainly much simpler than one way up by the GE junction. Also, this really is a great treatment for reflux, especially acid reflux, and essentially minimizes the risk of bile reflux. How do we know that? Well, so far in the last 10 plus years, we have done 6 conversions of a sleeve gastric bypass to the Roux-en-Y gastric bypass explicitly for the reason in 5 of those patients of reflux symptoms with evidence of some bile. I wouldn't say that the GI doctors would say, yeah, this is bile reflux. What they would say is this person has some gastritis, maybe some esophagitis, certainly symptomatic, and we see some bile. Regardless of the point of the cause, we believe that this has been extremely successful in those 6 patients of resolving their symptoms. One of the patients, remember I said 5 were due to reflux, one was due to a non-healing ulcer at the gastrojejunectomy. Her repeat endoscopy 6 months post-op after revision of her gastrojejunectomy showed that the anastomotic ulcer was gone and everything looked fine and there was no esophagitis or gastritis. All right, so comorbidity resolution, et cetera. When we look at our numbers as compared to the averages taken from the MBSA-QIP database, we're slightly better than average. We're excited about that. Is it because our Roux-en-Y gastric bypass and our OAGB has a little longer biliopancreatic limb than a lot of what's reported in the literature? Probably. It's certainly not as aggressive as many have reported, but about 1/4, 3/4 is about what we're aiming for, maybe slightly less than that. When we look at the 1-year data, we get these results. 2-year data, you can see they're very sustainable, just good news. Not a big change in 2 years. We have some 3-year data. Unfortunately, I'm going to put in a little complaint here. The MBSA-QIP has hand-tied us as far as developing long-term data, and we can't even make these charts anymore. Some of these are a little historical, unfortunately. We're not happy about that. I'll certainly complain about it at our reaccreditation meeting in the fall. 1-year post-op comorbidity resolution data. The main reason for putting this in is to compare sleeve gastrectomy to gastric bypass. This would include both our RNY and our OAGB patients. To explain a little bit, we did a study a little over 10 years ago of 555 patients on whom we had done RNY, as I showed you, and OAGB, SGB, as I showed you. Was not prospective randomized. It was based purely upon whether they had a certain insurance company or not. We would do an OAGB on everybody if we could, but some insurance companies won't pay for that, so we do an RNY gastric bypass. That being said, we looked at the data in those patients of comparing the RNY to the OAGB patients, and they were extremely close as far as weight loss, comorbidity resolution, etc. A tiny advantage to the OAGB as far as resolution of diabetes and hyperlipidemias, though. But why I said that is if you look at this bypass, you can, in your mind, substitute the word bypass. You can substitute in there the word OAGB because the results are so similar. So if you compare bypass, OAGB, to sleeve gastrectomy, you can see there's some advantage as far as resolution of diabetes. Hypertension, slightly better, not dramatically. Same for sleep apnea. Hyperlipidemia resolution is significantly better with gastric bypass than with sleeve gastrectomy, and the weight loss we all know is a little better. Certainly the most recent large studies out of Europe have reaffirmed that. That being said, to clarify, we use very strict medical definitions for resolution of diabetes, hyperlipidemias, et cetera. They're off medications with verified normal laboratory results, et cetera. It's not just our impression. We look at it 2 years, sustainable, which is good news. Pretty much the same slide showing that at 2 years, the comorbidity resolution for bypass is better for especially diabetes and hyperlipidemia. And of course, the weight loss is better. So, take home message. If we could do an OAGB on everyone, we would do it. We would certainly talk with them about it. It's certainly a better operation, apples to apples, than an RNY gastric bypass, especially with our technique. The stomach is exactly the same. Again, we think huge advantages to that. The only difference is whether we take the iliopancreatic limb, disconnect it, and reconnect it further downstream, as I showed you in that previous slide. The weight loss and comorbidity resolution are comparable to the RNY gastric bypass, slightly better in our study. There's minimal risk of an internal hernia. There certainly was one reported in the literature that I saw, but especially when compared to the RNY gastric bypass, significant reduction in the rate of internal hernia. Our take-home message is the risk of bioreflux being around 1% in an OAGB is much less of a concern than the risk of internal hernia and potential bowel ischemia, bowel obstruction in the RNY gastric bypass. The reflux issues, we converted 6 out of 2,500 patients, not a high number. Let's say we've lost a few to follow-up, multiply it by 4, that would give us around 1%. That is the number we've had in our mind and our experience, and every time we look over the data over years, we actually did a bioreflux look back about well over 10 years ago now, the risk was around 1% with I think we had a 95% follow-up rate on that study. Good news, bioreflux is easily diagnosed, internal hernia is not. Bioreflux, GI scopes them and says, hey, they got esophagitis or gastritis, whether it's related to bile or acid or whatever it may be, the answer is converting that person to an RNY. Pretty easy. You've got the SGB loop. All you do is divide it here, swing it around, and make a jejunostomy further downstream. It's really a fairly simple solution to a known but uncommon problem. When you compare it to the BPD, much lower incidence of nutritional deficiencies after OAGB than after BPD. Sure, a little better results as far as comorbidity resolution with the BPD, but with the difficulties in long-term follow-up that all of us have, we see the BPD as a significant risk for long-term nutritional deficiencies in folks. It's certainly a technically simpler operation than the loop SADI-S, which is essentially an OAGB done post-duodenal. Similar results, much longer, not loner, sorry for the typo, much longer follow-up and a much wider clinical experience. I think the SADI-S is probably a great operation, but the OAGB or SGB is also a great operation and technically much simpler. Our clinical experience, when we look at length of stay, but also really look at how that first month goes for the patients when they're going through a lot of physical and psychological adjustment, the SGB patients do quite well. Less complaints, less nausea and vomiting, certainly significantly less than after sleeve gastrectomy, lower pressure system. But in the immediate post-op period, the OAGB patients do very well. So again, I thank you all for your time and attention. Thanks for inviting me. If anybody wants to reach out to me, t.walsh @novanthealth.org. Happy to talk to anybody. Maybe we can exchange phone numbers, whatever it may be. But have a great rest of your day.
Okay, thank you, Dr. Walsh. At this time, we're going to proceed directly to the live surgical part of the operation. Dr. Walsh had to run to the operating room, and hopefully he might join us for the panel discussion at the end. So let's go ahead and present the case for today.
Yeah.
And
Hi,
we'll
everyone.
proceed.
I'll be presenting you the brief history of the case we are about to operate. Patient is a 46-year-old female with a weight of 141 and BMI of 55.15. She's a non-vegetarian by diet, and the comorbidities include osteoarthritis and obstructive sleep apnea. With HbA of 12.3 and albumin of 4.1, patient was a non-diabetic with HbA1c of 6.42, suggestive of early diabetes, and she is HIV HbA negative and COVID-19 RT-PCR negative. Ultrasound sonography suggestive of grade 1 fatty hepatomegaly. Over to Mohit, sir. He's ready with endoscopy.
Okay, so good evening, everybody. As we have a trend of doing intraoperative endoscopy to rule out lesions in the esophagus. So this is the picture. This patient looks to be a fit case for mini gastric bypass, but we do the intraoperative endoscopy just to rule out if there are any contraindications. The first thing we would like to do is look at the G junction to rule out gross esophagitis or any hiatus hernia. I do not see any. Then any lesions in the stomach, like the ulcers or a polyp or something which once we bypass this part of the stomach can make things difficult for this patient, and we might not have access to the remnant. Also, as you can see, this is the pylorus, and once I enter inside, I should be able to have a good view of the duodenum. And when we pull the scope back, we realize that there is no lesion inside the duodenum, which makes it difficult for us to do a mini gastric bypass here. So most of these lesions which are there can be picked up by doing an endoscopy, and that, as all of you know, is a must when we do bariatric surgery. Also, we look for hiatus, if any, and once we are sure that there is no other pathology, we can go ahead and easily do a mini gastric bypass. Now, as far as the port position is concerned, as you can see, we have one optical port which is just above the umbilicus. There are two 12 mm ports I am working with, both on each side of the optical port in the anterior axillary line, and two 5 mm ports, 2 finger breadths below the right and left subcostal angle in the anterior axillary line. So I am working with total 5 ports. We are using a needloscopic liver retractor of 3 mm, which is quite non-scarring. And I am standing on the right side of the patient, and my camera person is standing between the legs of the patient. So the first step to mini gastric bypass would be to enter into the lesser sac. So what basically we do is 1 to 2 centimeters below the crow's foot, we start to dissect this omental pad of fat. The trick here is that we try to remain as close to the stomach as possible so that we do not miss this plane. And mostly it is at most times easier to enter into this plane if we are close to the stomach. So you can see that I have basically opened this plane to enter into the lesser sac of the stomach. And once we are sure that we have opened the lesser sac, we always see the posterior wall of the stomach, the pancreas. As you can see here, we are able to have a good view. At this stage, I would ask for the gold reload, which I am firing, as you can see, from the right-sided port, which is exactly in line with the umbilical port, which is the optical port. And we fire this 2 to 3 centimeters below the crow's foot, making sure that we do not have a remnant which is getting obstructed. So this is a gold load. Some surgeons use a blue here. We usually would use a gold because I think that the tissue here is more thick, and as you can see here from the pylorus, the distance is around 2.5 centimeters. So basically trying to make a gastric tube which is as large as possible, as long as possible, pardon me. The second cartridge which we fire again would be without a bougie here, just to make sure that we do not sort of twist this tube. we fire this cartridge and also have a look at the remnant that it drains properly. So you can see that the remnant here, it drains properly. Now at this stage, I would take my third reload and would ask the anesthetist to bring in the bougie. So now the third reload can be fired, but the anesthetist will bring in the bougie. Once the bougie is there, it will exactly come into the pouch at most times. So you can see that this bougie now exactly comes inside the pouch. And once we are very sure about this bougie being into the pouch, as you can see, we can now go a little, but I do not use the bougie exactly as the main landmark to fire all my staplers, but it's mostly close to this bougie where we fire. So that's my third reload, which is fired obviously after putting the bougie in place. Can you push the bougie if you are able to? Push it more, push it more. Now, what benefit we have by pushing the bougie is that we can make the tube more straight, and this redundancy of the gastric wall can be avoided. So that's the benefit here of using the bougie. And I'm using a 3D scope, and sometimes in super obese patients, the 3D scope can pose challenges in vision because of large falciform, or because of, you know, we have 30° only available to us in a situation of a super obese patient. So these are some of the challenges, but most times we are able to manage with this particular scope. Now, as you can see, I'm using this bougie as a very rough estimate. It's not a, you know, very final estimate as to what sort of you know, pouch size I'm going to have. It is just more for the purpose of patency. And we usually would have a pouch of breadth of around 2.5 to 3 centimeters and the length of around 18 centimeters. We will definitely measure that for you. And that measurement will give you a very rough idea as to, you know, how we do this. Also, as you can see, I'm not dissecting close to the angle of his, very close to the fundus of the stomach, and just go with the blunt of my grasper without any use of energy source. And then I just sort of start to fire my cartridge with the cartridge blue tip seen on the opposite side. So here you can see that I have a little bit of oozing from the remnant, but that all stops. The blood pressure is pretty high here. So we just wait for the blood pressure to settle down, and this diffuse ooze is going to stop. Now, if you see here, the length of my pouch, it's starting from here, it's around 10, and then I can further start from here. So this pouch to me looks around 18 centimeters. Most times, you know, the pouch would be of the same length around. So this is around 18 centimeters. If I start to count again from here, this looks almost, I mean, if I go to the tip, it is 20, but if I count until here, it is around 18 centimeters of a pouch. This is pretty long, although I don't think that the length of the pouch essentially is going to make any difference in as far as how the anti-reflux mechanism would go ahead. All these pouch at the end of the day at 18 centimeters or 15 centimeters will have the same anti-reflux mechanism. So I don't feel that that makes any difference as far as I'm considered. At most times, what we can do is that once we have this pouch, we basically try and decide as to what should be the anti-reflux length. Now that, if you see, is around 50 centimeters at most of these places. But I feel that that does not matter. At the end of the day, we discussed in the previous webinars that it's basically the gastroesophageal junction or the lower esophageal sphincter. Push the bougie, please. Push the bougie. It's the lower esophageal sphincter which is in play to decide if we have a patent lower esophageal sphincter which is defective. Then at that stage, we have problems even with pouch as long as 25 centimeters. Now at this stage, I would try and bury all this omentum here. We have already made a pretty long pouch. This patient is not as bad a patient where you will have a lot of this omental pad of fat in the bowel and this, but there is some pad of fat close here with the omentum. and that's what can bother us. So this is the ligament of trides. I would again try and make sure that I'm counting it correctly, so that you can see, although there is a lot of fat, I'll still demonstrate is the ligament. I'm pretty sure we cannot see the inferior mesenteric vein, but yes, we can see the ligament. And now we can start to count. I have marking of 10 on my grasper, so that's 10, it's 20, it's 30, 40, 50, 60, 70, 80, 90, 100, 110, 120, 130, 140, 150, 160, 170, and 180. So 180 is the standard sort of length which we take for all our patients. I haven't changed this length since 4 years now, and we are following up with our data as to how these patients are doing. Initially our limb lengths were a little more aggressive, but after we saw that this develops more amount of protein calorie malnutrition and more so over multi-nutrient deficiencies in terms of micronutrients and all, we stopped making a very aggressive limb lengths. Now this is a tube which we have. I would still request my anesthetist to keep pushing the bougie. We have a little bit of trouble here because of a very thick pad of falciform ligament. So that's a little bit of a problem which comes in the way of our vision. Now this particular area here, we already saw the tube, but you can see that that's the area which needs to be dilated a little bit, and then we need to make sure that we are actually in the right plane. So most times now here we see the blue of the tube, and that's a confirmation of our plane. I would again move my stapler back and forth to make sure that I'm not into any false plane. At most times this can happen in super obese patients, that you create planes between the two layers of the stomach, which has happened with me. So we just use the bougie as a rough guide, plus one of the assistants can dilate it with a Maryland forceps, and most times we are able to bypass or maybe avoid that kind of a situation where you have a pouch where you staple between the two layers, which can cause obstruction at a later stage. Also, for the same reason, I sometimes, when in doubt, do a post-operative endoscopy. Now here we have this nice defect which we need to close. So my technique is very straightforward. We take a conels here at the caudal end of the anastomosis, and this is first started from inside the anastomosis. I'm using a endostitch device here, which we frequently use for doing these procedures. And also, I wanted to tell you the kind of suture length I'm using. So it's around, the length of the suture which I'm using is 45 centimeters. Now this is good saving of suture, because normally in laparoscopic surgery, when surgeons use conventional suturing, they cannot use more than 15 centimeters. But here we can use as long as 45 centimeters. And if in PIP you can see my view, I'm almost bringing my endostitch device outside the port every time. So that's the advantage of sort of doing this, that you always have a good amount of endostitch device coming out with a large suture, and yet you are able to manage this sort of a suture length. So that's the beauty here. And this suture can be very easily managed when we are doing the suturing, even though it's so large. So now I have secured my caudal end. I can cut my suture here, and we can come from the Kifilard end. So this is what, even if I leave this suture here, there's no pressure on the anastomosis. I can leave it and I can do the entire anastomosis without any pressure here. That's the, I think, advantage of doing a mini gastric bypass. You have a very low lying anastomosis without any tension on the tissue. And that's one of the advantages which I always said we have over the gastric bypass. And this anastomosis can be done by our fellows. It's easier than the gastric bypass. Now you see we have a huge liver, plus falciform is exactly head on, and fantastic job done by our cameraman, because he's the assistant is exactly trying to avoid the falciform which is coming head on due to the 3D scope. If we were working the same anastomosis in a gastric bypass, this becomes a big deal, because we are close to the GE junction where the loop goes with tension. The anastomosis is more difficult there, close to the GE junction, and it's more of a tension. So if I leave this here and I just start to suture, it does not create a difference. But in a gastric bypass, it's a lot of tension there on the anastomosis, even though we mobilize our mesentery to the maximum extent we can, but still that problem prevails. We have the same sort of a setup when we do a gastric bypass, and that's why I'm pretty sure that the pressure there while doing a gastric bypass anastomosis is almost 3 times what we face here when we do a anastomosis close to the transverse colon without any pressure on it. So that's the procedure. As far as the technical aspect is considered, I'm going to just measure the length of this tube and the length of the anastomosis, where we fired a 6 centimeters of the cartridge, but it becomes somewhere around 4.5 because we bury a little bit of that momentum, a little bit of that tissue, pardon me, inside, just a serosal layer there. So this is what we have. I measured that length for you already, but now the length above the anastomosis. So you see, this is around 10 centimeters from here, and I can just put a mark here, and then I can go above this mark, and we see that the length of above the anastomosis is around 17 centimeters. So 17 centimeters above the anastomosis, 4.5 should be the breadth of this anastomosis. The tube is around 2 to 2.5 all around the anastomosis. So I can just put it here, and if I measure it here, it's 3, but it's mostly uniformly 2.5 all around the anastomosis. We don't suture the staple line. We just use some clips for the anastomosis. But at this point, I would just try and do an endoscopy. There was some diffuse ooze which has settled now. We'll apply 2 or 3 clips, but first I'll do an endoscopy to demonstrate the internal anatomy, and then while my assistant puts the clips there, I can answer the questions for the interest of time of this webinar. So let me do an endoscopy. We don't do post-operative endoscopy regularly, but since this is a teaching case, I would like to do a post-op endoscopy just to see what sort of anastomosis we have, whether we have some intraoperative bleeding. And so blood in the esophagus, a little bit of it is expected because this is a fresh firing which we did. Now this is the GE junction here. As you can see, the Z line, and the staple line starts from here. And now this is a staple line, very minor ooze, but that's acceptable. We don't see a spurter or anything here, and that's a very wide anastomosis. So you can see both the ends. This is the first end here, and that's the other end here. So I'm going to rotate it at a 3 o'clock position, and I get to the other end of the anastomosis. So that's how the other end looks like. So see, I just bend down a little bit. I can see one end, and I go again around the clock and see this other end. I pull my scope back, and now from here, this view will show you both the afferent and the efferent loop beautifully. You can see nice staple line, and this is the anastomosis here seen. That's the staple line starting from the anastomosis, and when I pull it back, I can see this nice tube being formed. So thank you very much, everybody. If there are any questions, I'll be more than happy to answer in the meantime. Thank you.
Okay. We'll open it to the faculty and the moderators. Any comments about the operation so far?
Yeah, Mohit, again, it's very, very nice. Okay, but I have, today we heard from Kolar about the original technique. Okay, and I see that you have some changes. Mohit?
Yeah, I cannot hear you. Can you repeat the question?
I said that today we heard about the original technique from Kolar, And
I cannot, can you repeat your question? I could not hear anything in the previous part. Can you please repeat it?
Yeah, he's just starting. Listen.
Okay.
Okay, we today we heard about the original technique from Kolar, and I think that you change and you standardize the technique. You think that's your technique because you have a modification. Also, I have also my own modification. You can have better results from this modifications.
Oh, actually, my point is that everybody can have different technique. We standardize our pouch length to 17 centimeters above the anastomosis and make this anastomosis. And also our tube is not twisted, it's straight. As long as the tube is not twisted, the anastomosis is straight, it's not looking like maybe it will have a twist or a stricture. I think any technique would do. At the end of the day, it's a single anastomosis. So everybody can modify it. Yeah, somebody can have an anti-reflux stitch. Some surgeons can, through suture the staple line. Some can do the anastomosis anterior to the staple line, but we are very happy with what we have done as of now.
I think that the anastomosis is very large because you use 60 millimeters. What do you think about that? We talk that between 2.5, 3, 4 maximum, but I think that I saw that your technique that you use 60 millimeter cartridge.
I think at the end of the day, when we see this, it will be 4.5 centimeters, not 6 to be very honest. You fire 6, but while we do all this suturing, it turns out to be 4.5. Yeah, but we make large anastomosis because we believe that this will cause some amount of dumping, which will change the habits of the patient in terms of eating more of proteins and less of carbohydrates.
My last questions about the hiatal hernia. Okay, in case of hiatal hernia, which you prefer to repair or to leave? Like
if there is a hiatus hernia, I would never do a mini gastric bypass. I would repair the hiatus if it's large and then do a gastric bypass. Or if it's a small one, I'll just do a gastric bypass. And I don't do mini gastric bypass on patients with hiatus hernia.
Wei Jei Lee, any comments so far? Dr. Lee?
Excuse me?
Do you have any? Go ahead, Neymark.
I have a question.
Thank you.
Yeah.
Okay, I can continue. Mel?
Yeah, go ahead.
Okay. Dear Mohit, nice to meet, nice to see you, and it was very fast work. Thank you. But one question about hemostasis. Do you think it's safer to leave the staple line without some procedures for hemostasis?
Well, I use clips, and we would clip this entire line, both the sides. We don't suture. We have done some 5,800 mini gastric bypass with 0.02% of re-exploration rate because of bleeds, and almost I think negligible rate of less than even 0.01% of those who have been transfused. So we are happy by using clips for both the sides of the staple line.
Okay, thank you. Because I don't see now, and I ask you. Thank you.
Just one small comment. Mohit, first of all, congratulations. Very nice case. About the point which was raised by my friend Nasir, I just want to clarify that the basic principles of mini gastric bypass, long and narrow tube and a wide anastomosis, a non-obstructive anastomosis, and keeping the vascularity intact. If you look at this case at the end, everything around is pink. Inside, everything is pink. There are no blue corners, no ischemic areas. So ultimately, at the end, because Mohit has, a vast experience, he has completed this case, as I noticed, including the endoscopy in 14 minutes.
So, which is, I would say, congratulations to whole of your team, the kind of work which you are doing. And definitely you are following all the principles of Rutledge technique. It doesn't matter, we don't have to go exactly the same way, but eventually you're making a long, narrow tube, vascular anastomosis, and a wide anastomosis. Thank you very much, Mohit. Congratulations.
Thank you, Professor. Thank you.
Professor Antozzi, any comments?
Well, I feel like the black duck here in this webinar because we perform Dr. Carvajo's type OAGB, and there are some differences that I believe that what Dr. Bhandari said is true. We can change some things, but mostly we have to perform the techniques with all the topics that the technique was described at the beginning. And I think that for me, what I learned here is, or what I take home, a message that I take home is that the length of the tube is a primary tip that we have to be aware of. I believe that a long tube, it's important to avoid reflux. As we know, reflux is seen in this kind of technique, but sometimes having bile into the stomach doesn't mean to find reflux and doesn't mean that you have bile inside the esophagus. However, we always do an anti-reflux valvula, that it's part of our technique. And what I'm most afraid of is that you don't measure the length of the small bowel. And for us, this is an important step. We measure the length of the total length of the small bowel, and we use a percentage to be bypassed. And as you know, I'm from Argentina. Argentina is a country that eats a lot of animal protein food, meat, and we don't really see important malnutrition deficiencies. But during the first 2 years, we have patients that need to be protein replaced, and we need to be aware of that. So I am afraid of that step that you don't use, but I think it's a very, very good modification to the original Rutledge technique, because I think that, I don't know if Dr. Lee said that, but obesity is a variable disease. Not all the patients who function the same way, not all the diabetic patients are going to respond the same way to the same technique. So I think that we need to be variable surgeons. And be a variable surgeon is not to standardize a technique with a length of the small bowel or with a type of technique that we are using. That's why we prefer to perform a technique where we measure the total length of the small bowel and do or use percentage and not a standardized length. So I feel kind of different in all the opinions. I have to congratulate Dr. Bhandari because I think it's the most quickest surgery performed ever in the history. So it's been a really, really nice to see you operating.
Can I make some comments? Can I make some comments here?
Go ahead.
Yeah, so I think you've made a very valid point of counting the entire bowel length. I have a caveat here, or maybe I have a contrary view. See, we would do something when it is very necessary. Now, we have been doing gastric bypass, and I think across the world, some 10 lakh gastric bypass, over 1 million have been performed. And the combination of BP limb plus elementary limb, most of these gastric bypass have never been more than 200 centimeters. And I know that not a single gastric bypass surgeon counts the length of the entire bowel. So to answer your very valid, your valid anxiety or your valid concern, I would definitely measure the length of the entire bowel if I go beyond 200 centimeters. But the gastric bypass has taught us that most surgeons who have done bypass, a combination of a BP plus elementary limb, about 200 in most series have never ever, I have heard that they calculated the entire length. That's number one. So I agree with you. Yes, you have a valid concern of a short bowel syndrome, and we should be more concerned than you because we don't eat animal protein as good an amount as you do in your country, but in Argentina. But I would definitely measure the length of the entire bowel if I go above 200. Here I'm restricting myself to below 200, so we haven't done it. And we haven't found short bowel. I just remember one case in the 5,000 plus cases I have performed. So it doesn't make sense for me to calculate the length of entire bowel if I am going below 200 centimeters. Above 200, yes, I would. Plus, I would also want everybody to know that there is a good incidence of damaging small bowel while you measure it in entirety. And these injuries to the bowel can cause enterotomies, which might go unnoticed. So I would not want to enrisk a patient if I'm doing a bypass less than 200 centimeters.
Very good.
Dr. Wei Jei Lee, any comments?
Yes, I would like to congratulate Mohit. It's a nice operation. My one question is, you're doing endoscope during surgery. So what if you find some polyp or hyperemia over entrance? What will you do?
So usually hyperemia over antrum, we don't bother too much. You know, we are now regularly doing the breath test for the H. pylori as Dr. Fobi recommended, and now we do it regularly. So we treat these patients irrespective. We don't cancel a surgery, but antral hyperemia is not a contraindication to mini gastric bypass for me personally.
What is the percentage you need to change your operation?
Okay, yeah, that's a good. So we have a very good data. We do intraoperative endoscopy and we don't do preoperative endoscopy, and 2.5% of our patients have changed the surgery. For example, if we find a hiatus hernia, as I said, I would not do a one anastomosis, but would go for a standard Roux-en-Y. Similarly, if I find a very cirrhotic liver, I would never do a one anastomosis and go ahead and do a sleeve. So that's percentage in our data is 2.5%, where we need to change our decision on table, and the patient has to give a valid consent for that.
We also do endoscope during surgery before, until we had the experience of one esophageal cancer, 2 early gastric cancer, and several cases of the polyp over entrance. We change our policies to do pre-operative endoscope before surgery. Otherwise, you need to cancel operation sometimes, and it's sometimes really a difficult situation. Okay.
Yeah, if I have been, I agree with you. I think for Cantonese and another population in your area, I think you have a very high incidence of gastric cancers, and I agree that I think preoperative endoscopy there makes a lot of sense. But out of not a single case we could find lesions which were malignant. We did find some gastrointestinal stromal tumors which we biopsied or did a frozen. We have a frozen facility available here, but not malignancy. It's not a area is not a very high area for endemic for the stomach cancer. So we still do this practice. But I agree with you. If we have such a problem, it's difficult situation, and you cannot cancel the surgery. You have to cancel the surgery. I agree. I mean, that's why preoperative and intraoperative endoscopy is a subject which is a little controversial, because in areas which have a very high incidence of stomach cancers, there you may end up canceling the procedure. That is not very good, which could have been detected preoperatively, and I absolutely agree with you.
Dr. Chevallier, any comments? Jean-Marc, I think he might have left. Okay.
Well,
Dr. Sakran, you have any comments?
I'm here.
Oh, okay.
No,
go ahead,
I will congratulate Mohit for this excellent case and ask him one question I'm often asked. When do you decide to do a Roux-en-Y bypass? When do you decide to do the second anastomosis?
Okay, so it's very clear. If I get a patient who has established GERD, and symptomatic GERD with esophagitis, I would never do a mini gastric bypass. I would do a gastric bypass there, as you asked. Similarly, patients with hiatus hernia, I never do a mini gastric bypass. We always do a Roux-en-Y gastric bypass. The third indication probably is that we have a diabetic patient, but he is not ready or not keen for a very good follow-up, and he lives a lot of distance away from our center. So there we are scared to do a one anastomosis because of lack of follow-up. And there we offer a conventional gastric bypass, and obviously we banned all our bypasses, so a banded bypass. The fourth situation would be patients in India sometimes cannot afford the cost of supplements. There I would not offer one anastomosis, but and there, if there is a need for a metabolic procedure which is strong, I would do a conventional gastric bypass. So these are some of the situations where primarily I would do a Roux-en-Y gastric bypass. It still finds a place in our algorithm. Still 30% of the procedures are performed would be Roux-en-Y because of hiatus hernia or established GERD or severe esophagitis or type 2 diabetes on insulin with patients not keen for a follow-up or not affording the cost of the supplements.
Yes, because I think the morbidity of the second anastomosis is underestimated in most of the discussions, not only internal hernias, but also abdominal pain. In the Omega trial, abdominal pain were much more frequent after Roux-en-Y than after one anastomosis bypass. So
I absolutely agree with you. I think if the jejunostomy is not as wide, and if the defect closure is not, the internal hernia defect closure is not as technically sound as the principles of gastric bypass surgery dominates, we will have chronic abdominal pain. It's very common. At our center, we never had a higher incidence of chronic abdominal pain in Roux-en-Y as compared to mini gastric bypass, because we closed both our defects, and with the passage of time, we have made a very robust technique to close both internal hernia defects, which are the mesenteric defects and the Peterson space. So yes, I agree. I mean, it can happen if the jejunostomy is not wide, the hernial defects are not closed. Chronic abdominal pain is very common after Roux-en-Y, more common than the mini gastric bypass.
thank you.
Dr. Mahak, do you have any comments? Is he there or is left for the university? Okay. It's been a very nice presentation. You all have done a fantastic job. There are still areas where we have to make some modifications. There's still room for various modifications. But I think what we'll get out of this, what Dr. Antozzi said, we'll make a long pouch and non-obstructive gastroenterostomy and follow the patients. So with that, I'll thank you all. And we have another webinar next week, same time, same place. And at this time, I'll have Dr. Bhandari thank everybody, and then we'll go to the promo for the next webinar. Thank you all very much.
Thank you.
Thank you very much, everybody. And I can say that most of these webinars, I have learned the most, because every time I listen to speakers and the different technique, like today, I absolutely agree that I should reflect upon, sit with Professor Fobi and see if we need to calculate the length of the intestine. Although, honestly, we have discussed it 100 times and we derived some conclusions. So thank you very much. I always learn and listen to leaders like you. And thank you very much for taking out time to be on this virtual bariatric university. And I hope all of you keep safe. The COVID numbers, like in your country, are also increasing in our country. And I hope we have good times ahead and we fight it all together. Thank you very much.
Thank you.
Himanshu?
Thank you. Bye.
This webinar was recorded, available on our website.